That's 2 going. Right. Okay, so what we're going to do now is an ankle examination, and we're going to do parts of the Saltaps examination procedure and move fairly quickly towards active passive strength. So what I'd like you to do first, Jade, is if you can move a little bit further back onto the couch, but still with your feet over the end. The handling position is important here, and my preferred best position, can you just flex that knee so it's out of the way, that's it, is to wrap the hand around like so, so that the fingers go up the back of the Achilles. Then the foot can rest on the forearm, and then the other hand can clamp over the midfoot region like so, and from here we've got a nice stable base that we can resist movements, and we can control and get pure movements in each of the planes that we're looking for. So if we quickly go through and assume that we've done the active movements with the client standing, we would then do passive movements. So from here I would passively dorsiflex to the end of range, checking for any pain or discomfort on any of these movements. And obviously if there's any pain or discomfort through the normal part of the range, it would indicate joint lesion. When we get to the end of range, there's a possibility that it could be muscle tissue on stretch at that point. We can check inversion. To do that, we make sure that the ankle is dorsiflexed to 90 degrees, so it's in what we call a neutral position. And we can also do eversion as well. Now we can do resisted movements. So Jade, can you just gently start to draw your toes towards your shin, please? That's it. Good, and stop. And then the same, pushing away and just gently starting. Good, and stop. Make sure your instructions are clear when you're strength testing. Obviously, if you're looking for injury, you want the person to stop as soon as it's painful. So you want a nice slow build into contraction, and we're looking for smooth movement patterns. If there's any sort of juddering or cessation in the contraction, it's an indication of some sort of inhibition going on, which may be down to pain or discomfort. So resisted inversion, it's always a good idea to show the client this movement, because not many clients will understand what inversion is. So again, we dorsiflex to 90 degrees. Jade, that's the movement I want you to perform, and I'm just going to resist. So again, gently building up, good, and relax. And now in the opposite direction in that movement. Good, and relax. Okay, so that will have checked both passive and strength for general problems. Then we can get on and actually start to do some special tests, although we've already done some of those as part of those movements. So for example, when doing passive eversion, we are testing the deltoid ligament that sits around the medial malleolus, and if somebody has forcibly everted the foot, that would be where the ligamentous damage would have been suffered. That's the rarer of the two types of ankle sprains. The lateral one, if we can just swap legs so that we can see, the lateral one involves two main ligaments down here. One will be the calcaneofibular ligament here, and the other one, much harder to palpate, but certainly around that sort of spot, is going to be the ATFL, or the anterior talofibular ligament. And now we combine some of those passive movements to test for those. So once again, I would normally be on this side testing, but just so that the camera can see this, I'm going to work from the opposite side. And from here, for the CFL, or calcaneofibular ligament, I would do inversion on its own, and then to try and test ATFL, I'm going to combine that with plantar flexion. And to pinpoint that, you may just need to circumduct a little bit at the end of range, because that ATFL is in there, and it's difficult to stretch and get absolutely right each time. So just a little bit of movement like that will help pinpoint and find that particular ligament. Okay, on to other special tests, and still sticking with sprains. A common one is a syndesmosis sprain, and this is where the athlete has the foot firmly fixed in the floor and goes to twist and turn, and the foot stays put. And what happens is that the talus in here turns and forces the two lower leg bones, the tibia and fibula, apart, and causes a sprain not only in the interosseous membrane here, but the inferior tibio-fibular ligament that spans this joint here. And so we recreate exactly what's happened on the playing field. And if I do it with this leg here, we again take the foot to dorsiflex position of 90 degrees, stabilise the lower leg like so. Then I move my arm just to the medial aspect of the foot so that I can now externally rotate the foot like so. So you can imagine the athlete standing on the ground here, twisting and turning that way, and the foot staying put. So we're just forcibly prising those bones apart, and depending on the severity of the injury and the signs and symptoms that you're presented with, you would probably start with a gentle test first and then progress on from there. Okay, moving on to some other tests. Morton's neuroma is a condition that is normally derived from friction around the nerve, and it's usually between the third and fourth metatarsals. So typically it's going to be in this area, and the signs and symptoms that the athlete will suffer will normally be pain or numbness transferring down into the third and fourth toes. The condition is often caused by repetitive kicking of a ball, or perhaps tightness of footwear, tight football boots, that sort of thing. And so again, we just replicate exactly what's happening to cause the problem in the first place, and we will just do a squeeze from either side of those metatarsal phalangeal joints, and that should cause enough pressure on that nerve to exaggerate those signs and symptoms, and that would be a positive sign for a Morton's neuroma. Okay, if we now check for stress fractures, there are various ways of doing this. If we suspect that there are any stress fractures in the toes or the phalanges, we would simply do percussion tests by working along the toes, working from the ends, and just first of all lightly flicking, and then a little bit firmer to the ends of each toes, and just stabilise the toe as we do that. If there is a positive sign of a stress fracture, it should be felt in a localised way within the specific phalange that the percussion test has been done on. However, sometimes the vibrations may transfer into other bones within the foot, and pain may be felt elsewhere. Other percussion tests that we can do, we can check for stress fractures in the tibia and the calcaneum by moving the client's foot into dorsiflexion and then using heel of the hand to strike the heel of the foot. Just first of all a gentle thud on the sole of the foot like so, and then a little bit further, and you can see the vibrations transferring through the lower leg in that fashion. Other stress fractures we can check for and other fractures are within the fibula, and we can do what we call a squeeze test. Would you put your other leg straight for me? And the squeeze test is literally squeezing the two lower leg bones together. So the tibia is the weight-bearing bone, and the fibula is what we describe as the splint bone, sits down the lateral aspect. If we try and squeeze the two together, the only one that is likely to have any stress put through it is the fibula, because the tibia is so strong and so thick by comparison. So we literally squeeze our way up the lower limb like so, and again, any indications of pain or discomfort may be an indication that there is a fracture or a milder form of stress fracture in that area. Okay, other forms of nerve damage, sorry to keep you switching over, We have various tunnels that provide for vessels around the back of the medial malleolus. So we have blood vessels and nerve supplies that track around the posterior aspect of the medial malleolus here. And we can just compress in this area, and if that alone causes any sensations that are radiating down into the foot, that's an indication that there may be a problem with the nerve being irritated. And then we can progress on to what we call a Tinel's sign by just tapping in that channel just behind that medial malleolus. And again, that may cause radiating pains down in that area. Okay, I think that concludes everything that we would do with the client in the supine position. So Jade, if you can just turn over onto your front, please. And that leaves us, I think, just one more test to check for the integrity of the Achilles tendon. And if there's a suspicion here that this has been ruptured, then what we do here is the Thompson test or the flipper test. And all we do is squeeze the gastrix and soleus muscles like so, and by doing that, this mimics a contraction of this muscle and draws the foot into plantar flexion. Now if that doesn't happen, that's a sure indication that the Achilles has been ruptured, and obviously the union there has been severed, and that action wouldn't be possible. Okay, sorry. Back onto your back, please. Two more tests that we need to do. Our draw tests, anterior and posterior draw tests, and there are two ways of doing this. So it will depend on you as to what your preference is, and sometimes the size of the athlete and how you handle them. So one way is to position the client exactly as Jade is now, and I would stabilise the foot by just holding and pushing down into the couch like so, and then I'm going to grasp the lower leg and literally pull forwards and push backwards. And so we're testing with a posterior and anterior draw test, both the general anterior ligaments and the posterior ligaments of the ankle joint to check for the integrity there. And there should be minimal movement, so if we just look at that, you can see a little bit of movement as we do that there, and then pulling forward here. Now what's confusing about the two different ways that we do this, if I am pulling the lower leg forward, this in fact is a posterior draw test because the foot effectively is moving backwards underneath the tibia and fibula. And of course the opposite is true here. If I push that back, that's an anterior draw test. Now another way of doing this, which in my opinion is a little bit more straightforward, is with the client with their foot again extended over the edge of the couch. If we go back to the original handling position, but instead of the hand here, we will stabilise the lower leg, and this, in drawing the foot forward, is an anterior draw test. And I find it a bit more successful in getting that little bit of a shunt in the joint there to test the integrity of the ligaments. And then I would swap my hands around, stabilise the foot, again ensuring that we keep it at 90 degrees of dorsiflexion at the ankle joint, and just do a posterior draw test, looking to see how that moves in that direction. And those tests can be done either for acute injuries, obviously a little bit more sensitive in those instances, or to just check the general laxity and stability of that joint. I think that concludes our ankle examination for today. I can breathe. God, that's hard.